So welcome back to episode number 4 of our IBD Within Endoscopy Essentials series. And welcome back, Raf Bisschops from Leuven.
Thank you, Thomas.
So last time we stopped at mucosal healing and the peculiar thing that it's not complete healing, at least in the study definitions.
Yes.
So shall we talk about complete healing and what it means and what are the scores, etc.? So I'm very curious to learn more.
Well, let's focus here on ulcerative colitis because
yes,
this is the field moving forward, and this is a field that is moving forward. So the relatively old definition is to have Mayo 0 or 1 as mucosal healing. And this goes back to what we discussed earlier. What is the outcome for the patient? And again, this goes back to clinical trials like one of these, where you can see if you have a score of 0 and 1, that this mucosal healing at week 30 predicts clinical remission for those patients that are in maintenance. So in patients that had before that a moderate to severe UC, so Mayo 2 or 3. And that's why they say, okay, if you reach that stage and you're going to continue therapy, probably that's good enough. But and there's other data that if you reach that stage, and again, if you look here, the full line and the dotted line on the top here are both Mayo 0 and 1, that also reduces the need for colectomy after 1 year. So that's where this combined Mayo 0-1 score comes from as an endpoint endoscopically to assess. But there's more recent data, and I just show you one, but there's more and more data coming out that if you look a little bit more into the distinction between Mayo 0 and 1, that in fact there is a difference in outcome as well in more recent findings. And even more so if you use the UCS score, there's a difference between 0 and 1 as well. So complete, nothing with normal vascular pattern, or those who still have ongoing erythema. And even on top of that, there's now more and more emerging data that if you take biopsies and you can score that for inflammation, and there's complete, deep histological remission, even that has a better outcome in terms of corticosteroid-free remission for the patient than when there is still ongoing inflammation.
Even within the group of endoscopically normal mucosa.
Exactly, even within the group of Mayo 0 and 1. So the question is indeed, how deep do we need to go, where we're going to define our target, and I think these are things that will come out in the future.
They will, but at least for us it's important to better score those mild cases and not saying, oh, it's mild, let's forget about it.
Exactly. Yeah. So the question is indeed, what are you going to do with this here, right? So if the patient's used to have a Mayo 3 and you put them on any therapy, let's say biological, and then the patient comes back at this, assumably there will be less symptoms, I think, right? But is this enough? And do we need to push forward? I think, well, most will wait now, but maybe the algorithm in the future will change. And I think also to make that a little bit more granular, last time we already talked about what the difference is between UCS and Mayo, that it allows like a better differentiation within the same spectrum. And I think we can even go a little bit deeper with more advanced imaging techniques like virtual chromodoscopy. And that's what Marietta Iacucci's project was about already 8 years ago, where we sat together in a group. And the Picasso score comes from the fact that we did this near Paddington Station in London, where we sat together and said, okay, let's have a good look at the features we see in those videos with virtual chromodoscopy, and what do we see beyond ulcers and erythema, really looking at the vasculature that is accentuated. And this was then incorporated and then kind of graded. Okay, we can also see microerosions, like a little dot. So that probably corresponds to the microabscesses, the cryptal abscesses that the pathologists see. And then we can see whether this is patchy or not.
So there is an overlap with the other classification. So it's not only in cases where you see a seemingly normal mucosa, you go deeper, but it's a differentiation of the score, which might help in the mucosal healing.
Exactly.
To further subclassify.
Yeah, and the idea was also, this was like at the dawn of artificial intelligence, that we had in mind, maybe we can identify features that help us discriminate better in the lower end of the disease spectrum, whether there's still something going on or not.
But it's pretty complicated again. It
is really complicated.
It looks a little bit Japanese.
Yes. It does indeed. But I think the bottom line is, as you said, like again, in the severe disease spectrum, we don't need this, right? We see there's ulcers, there's bleeding. And this is also incorporated here. I think it's really important to draw the line when we have no mucosal defects and normal vessels, that we can really better assess a deeper mucosal healing with these techniques, and that was also correlated to histology.
Can you go back for a second? Sure. So this line is between normal and slight abnormalities.
Exactly.
But maybe the one category, would you see it on a maybe superficial normal endoscopy? Is that maybe the cutoff where?
Well, we can have a look at the examples.
Yeah, okay.
So let's first, well, the histology, these are the correlation with the Mayo score and so on, and the other scores in histology. Well, this is clear, right? So, but what we looked at basically, so obviously we looked beside the ulcers, but we tried to identify these features like these dilated vessels, like here, also from these features. But this is clear, and this is also UCS, and the Picasso score is also high then, because we have all these features of intermucosal bleeding, which is here, like these dilated dots here. But when we go to...
I like the acronym, by the way.
Yeah. Yeah, it was Marietta's idea to call it that way. And then the features with healing is really if you have continuous regular crypts, a bit like you have in a normal colon. And for that, I think you also need like either a bit of zoom or some chromendoscopy to really assess the crypts. And then these vessels are just surrounding the mucosa like you have, right? So you can go closer and then you can discuss, yeah, this looks normal, but you can actually confirm this, and whether you need this or not, I'll show you in the next examples, because here there's nothing going on, so we can see everything is nice. And then if you switch on this virtual chromendoscopy, you can see the round pits, right?
Yes.
And the nice,
yes.
So even without the zoom. And these were the features that we were looking at during that exercise and the validation process. And then you have also crypts and vessels that are not visible. So scarring is also defined as healing, like for instance here. So we included that in healing. But you can see the normal vessels in between here.
Yeah, I think that's very important, because that's by no means a normal mucosa. It's a scar type healing, but on biopsy you can find no inflammation.
Exactly. Yeah. So we should also identify this. That this is not ongoing inflammation. And then even you can have sometimes some discontinuous and dilated elongated crypts. So we call this like some regenerative changes. They are difficult to see, I think, with normal white light. But again, if we change, this was the old eye skin feature that we used for this development. But you can also do this with any technique where, these crypts are not really roundish or a little bit more dilated, but they're still nicely surrounded by the vessels that are not dilated, right? And I come back to these slide changes now, because this all looks nice and normal, right?
Yes and no, huh? Is that a really normal mucosa?
Well, it's a bit regenerative.
Yes.
But if you look closely and long enough, so you need to take some patches to assess doing this. But then you can really discriminate this from these microerosions and crowded vessels. And this is a nice example. Again, this is patchy disease, and you have to look for it. And then you can see the erythema here already. But then if you switch, and it's obviously visible with white light, but I think you can discriminate it better. Now we put on the surface enhancement, so those crypts and the dilated vessels are actually surrounding the white dots of the crypts here. And they are more accentuated now with the surface enhancement. And then if you switch on the virtual mode, it just becomes even more apparent. And then the microabscesses, I'm just going to pause the video here. If I can click it here, are those little white dots here, you see? And this is something you don't see on white light. If you go back to the white light, you don't see that here, right?
And you had a normal vasculature only at the left side of the picture.
Yes, exactly. Yeah. So again, and this is what helps you to really, I think, discriminate a little bit better in this lower disease spectrum, especially if you want to say, I want to have complete mucosal healing. And then we still need to define how this would affect the patient. But indeed, at least in a patient that is for a long time on biologicals, if you consider stopping that, maybe in this patient not, because you can still see microabscesses, right? And there's definitely maximum Mayo 1 here, and UCS 1 probably. But those microabscesses here, they correspond to ongoing inflammation here, and that is nicely accentuated here.
If you wouldn't have any reddening here, is there a form of healing which is kind of hypertrophic or hyperplastic and it's still healing?
Well, you can have like the serrated changes in long-standing colitis, so that looks a bit like a serrated lesion. And you have then these elongated crypts as well, which are also corresponding to healing. But that's different. So I think what we identified those little white dots, we looked at it a long time, and we could correlate that as being those crypt abscess. And I think you can only see this with advanced imaging techniques like this one, or also other techniques like NBI or BLI and eye skin. So here's another example with BLI where you can see the same features. You can see those bleedings here better, and you can see those dilated vessels. Obviously, it's clear. But even more the subtle changes, again, they are, in this case, Crohn's disease, they're accentuated better, that there's still some ongoing inflammation here and there, or even with the LCI, as you can see here, where this is more accentuated. So this is really important because we could see that these features like micro erosions and crowded vessels are really associated with.
So that means they never have a normal histology.
No, they don't have a normal histology. There's still ongoing inflammation, right? And that's where
in the completely normal endoscopic picture, is there sometimes an inflammatory pathology?
Not when we have a Picasso that is below 3. No. No, we did it.
So you can predict histology.
Well, if you do your best, because it takes a little bit of effort, obviously, you need to clean very well. So, and you have to stay longer. So it's more than just a glimpse of the colon and then see what's going on. So you really have to look for those minor changes here. But I think the problem still remains is inter-observer agreement, right?
Yeah.
So
as with every classification.
Yeah.
No?
And this is the old Barron classification. And as we said before, if you have this very bad inflammation, then everybody, some people still think it's nothing, but most people will say, okay, this is bad. But if you look at the lower end of the disease spectrum, it's all over the place, and the agreement is really low. And that's where I think we need to have some objective assessment. So, because we can use the advanced imaging techniques and say you do that, but many people are not even using the Mayo score in their reports, let alone the UCS, let alone they're going to use the Picasso score. So in the end, we're going to end up with some automated scoring systems. And so if you want, we can talk about that.
One of your hobbies, yes.
Yes, absolutely.
I think this nicely would round it up.
Yeah. So it's a little bit futuristic, but it's happening now. And the question is where we're going. The why is because, well, it's operator dependent, and it may actually be important for the patient. And there are actually now two things that have been developed, mostly academically, sometimes also by pharmaceutical companies or companies as such. And they're focusing either on one point to predict the scores that are already there. And we may wonder if this is enough. Probably not. It helps for the trials for sure, and that's where major interest is. And on the other hand, we have automated assessment of inflammation that is related to histology. I think pioneering work comes from the group of Michigan that had a huge database, and they focused on the first, again, on the mucosal healing, but again, it was defined as 1 and 0. So this is maybe not perfect for the future, but it shows what the system can do. And you see that the differentiation between Mayo 1-0 and Mayo 2-3, based on central reading by their network was quite good. But if you go to 0 versus all the rest, it becomes as good as the human observer, which is not very good. The area under the curve goes down. And they extended this to videos with good accuracy. And what is nice about these systems, and that's where I want to come to, is that if you have a system like that, and this has actually been shown by this Chinese study, where you can actually make a map of the colon, right? And this, again, relates a little bit to the modified Mayo score, where you better get also an idea of the disease extent, but here very objectively you can take pictures or a section of frames every 5-10 centimeters, and then really have an objective scoring, which is also very nice if you put it in a map like this to show what the effect of a therapy could be.
It looks nice, but I think we shouldn't, we should mention that this is a lot of work to establish.
Yeah.
Because I think the gold standard for the endoscopic picture is probably the experienced endoscopist. And then you have histology, and to correlate everything, that's a lot of work.
Yeah.
And you have to look into the small print of the papers, what they've actually done.
Yeah, this is the output the system generates right now. So, and I think in the end it may be, but you still need to have the high quality pictures. Absolutely. I think with any artificial intelligence is important. And actually the Michigan group also validated this. What is very important, and this is something where the importance for the pharmaceutical company is about where they use the database of videos that was used in this study with a certain biological, and they conclude there that the thing is ready to be used. And obviously this is a major change. And somebody's very clever saw this market also, so Michael Byrne developed this system where they actually automatically analyze a video, and it's really focusing, I think, on the application in clinical trials, where you go to the hotspot in the video, can see where a biopsy is taken, and then it already predicts a score, and you can then check for it and manually reassess it and correct it if it's incorrect. But also you can see immediately that it can also generate like a total colonoscopy score. And I think this is really where we're heading to. So this is something that has already been published 2 years ago. So this is really ongoing. And I think this is really something that's going to happen. But again, it focuses on the scores, which in itself are not so perfect maybe, but they're still used in clinical trials a lot.
But of course, you have to make sure that the withdrawal is perfect, right?
Absolutely, yeah.
Although unless a robot takes over,
but this system takes also into consideration the blur parts, and it's on the grayscale there before. But obviously you need to have proper insufflation in order to have this nice map that I showed a couple of slides before. But I think the more interesting thing, especially if you come back to what I talked about the histological healing, is to take it one step further. And actually it's possible to predict histological healing based on endoscopic images. And this is from the group from Takanaka that worked on a system that appeared to work pretty well with a high accuracy, as you can see, not only for predicting the UCS score, but also for histological healing. And the nice thing about the system is here, you can find this paper in Gastro and the video as well, is that it will give you a confirmation of what you see. So here you can see the system will say healing. It's a remission case, but
a little bit scarring, but
a little bit scarring, yes. And this relates then to the histological healing, right? So, and the good thing, and maybe you can say this is a downside of a system or an advantage of a system, is that it will here, for instance, say, I'm not really sure. And then it will say, oh, take a biopsy to be sure. And maybe this is what we should expect from artificial intelligence at this point, that when the system is not really sure, we should take a biopsy. And when we got the confirmation.
Or perhaps you go into magnification and, next step of endoscopy.
Yeah.
Otherwise, we just pull back, which is very boring.
Yeah.
So maybe it leaves some work for us.
It leaves a little bit of work and it makes it more active. Huh? And what is nice about this system is that it again correlates to the outcome of the patient. So this is a follow-up paper of that, where they show there's less risk of relapse, less risk of surgery, and so on for complications in the long term if you show and you confirm with the system that there is complete remission. Similar work again from the group from Marietta, where they show that. But again, coming back to what you said, so it's a bit similar. It's based on the Picasso score. The features were then trained. And then you can see that you again can use the automated Picasso score to predict the outcome, a little bit like the study of Takanaka, based again on just the endoscopic images, but in this case also with the virtual chromoendoscopy, obviously. But we can also take this a little bit further to be a bit more advanced with zoom, even magnifying endoscopy like endocytoscopy.
Now we start flying.
Yeah, and red density. So that makes it for us as endoscopists interesting. So the endocytoscopy is really, again, a scope that magnifies us more than 120 times, and you really have to push it against. And then the system will make a prediction of ongoing inflammation or not. And this seems to be quite accurate, as you can see in this study. Another way of what we can do with images is quantify them and really analyze this. That's collaborative research we did. Peter Bosuit was doing a PhD on this, and this collaborative research with Pentax that we did. where we analyzed the image for its redness, and we corrected that for obviously the vascular pattern, because otherwise you would have in remission a very high score because of vascularity. And this was then integrated in a logistic regression to the Gabus score, which is a histological score, to come up with the RD score. So this will give you immediately a score that is displayed and quantifies inflammation. And I think what is important is that it relates to the histological healing, and you can actually define a cutoff. And you can also see that it changes. For instance, here is a patient who had a UCS 5 and then a high score, but after therapy you can see that it decreased. So that's one way to really look at the white light image that you have and use the features that are there from a technical point of view to correlate that and take it far beyond the Mayo 1 or 0 as we normally would do. The question is if we need that and how this will be incorporated in the future, we will need to see. But clearly, coming back to what we did with the Picasso, this goes also a little bit to that, looking at the vasculature, the microvascular changes. And this is what we studied in collaboration with Fuji R&D, where the assumption is that if you have ongoing microscopic inflammation, that the vessels will be dilated, the intercryptal distance will be, because of edema, will be increased. And this is actually a more simple approach, like with red density, you have a quantification. Here you go very into detail, but it's more dichotomous approach. And it's based on two features. You can have the number of number of pixels with bleeding that can be low. And if it's low, then it will be subsequently also analyzed what we call number of pixels with high density of vessels. So there are three possible things, like what we see now. You can see clear bleeding here, then it's easy, or you can have no bleeding with high density vessels that are dilated. And the assumption was that the left one would be histological remission and the other one non-remission. And we've currently further developed this last year to a prototype that was bedside, really predicting with a red or a blue button what you can do. So this is what we can do now, correlating well. And I think this is where the future will take us, maybe. But at least I think that artificial intelligence will help us to overcome the human interobserver variability. And also it will be interesting to see how this fits also in the outcome of the patients, because if we can really predict based on this, like in the paper from Takanaka, that patients in 4 or 5 years down the line will be doing well, then maybe we can stop therapy if we have a confirmation by these techniques.
Well, it's still a relatively small subgroup which has complete mucosal healing by endoscopy, and then we do deep diving here. But if the effectiveness of drugs becomes bigger, then this group will grow and this gains importance. Huh?
Yeah, I think so, yes.
Okay, Raf, that was fascinating. Thank you very much, and I'm sure we'll have you back when this develops further. Thank you.
Thank you for the invitation, Thomas.